Great, thank you, Charlotte. And so we now dive in to your experiences and your challenges, starting actually with best practices and lessons learned. So this is directly from what you shared in your applications. And Charlotte is actually the one who put together from the applications the summaries that we're going to share and discuss. So in this section, we're going to spend 25 minutes looking at some of these best practices and lessons learned. We're going to start with Paul Trini, and of course we'll be checking. Let's see if Paul, yes, indeed, is in the room, works at the regional level in Ghana. And let me see, Charlotte, can I ask you to summarize in 1 or 2 sentences this very dense slide? What is the best practice or lesson learned that Paul is sharing here?
So Paul is actually just sharing how they are using that integration of VPD investigation with other programs, that in a way that it helps in a limited resource context to do 2 things. That is the kind of like integrated tuberculosis surveillance with COVID-19 contact tracing and other VPD surveillance activities.
All right, now let's go to Paul. We're going to ask him to introduce himself and to share firsthand anything else in order to fill in some of the blanks, and then we'll be going to the WHO subject matter experts for their comments, perhaps follow-up questions, and just to help better understand how an example like this fits with the new global strategy. So first of all, Paul Trini, a warm welcome to you. Please do introduce yourself and tell us what else would you like to add to this story that you shared in your application for the course.
Okay. Thank you very much for the opportunity. So my name is Paul Trini. I work in Ghana as the disease surveillance officer for the region, that is Eastern region to be specific. I coordinate surveillance activities, and as part of it, vaccine-preventable diseases are not exempted. So I'm keenly involved in the vaccine-preventable disease surveillance by supporting districts that record vaccine-preventable disease in the investigation process. So per the system of operation, we have the district level, the sub-district level, and we have health workers who have been trained in the uptake of vaccine-preventable disease investigation. So when there is any vaccine-preventable disease recorded, right from the region, we support the district through to the sub-district level to the facility so that we are able to collectively address and investigate the vaccine-preventable disease. And for the officers, since they have been trained in the various angles, that is with regards to the investigation process, they don't do it in isolation. So like example, when a measles case is confirmed, the approach that is used in the investigation process for measles is applied at other diseases. So I cited an example that in the TB, when there is any case of confirmed tuberculosis, the approach is used, contact tracings are done, and then we are able to holistically use the same process to achieve our objective. So that is how, in brief, how the system operates in Ghana, where I operate as a surveillance officer for the region, and then support the district to ensure that we achieve our objectives in trying to meet the standards as Ghana Health Service recommends. Thank you very much.
Thank you, Paul. Now let's turn to the WHO team, and then we'll also turn to participants. If you'd like to comment, share your reflections, share your own practice. What does this look like where you work? So first, Dr. Anindya Sekar-Bose and Anna Minta from WHO. We'd love to hear where does this fit into the new global strategy? What are your comments, reflections, follow-up questions for Paul Trini from Ghana?
Okay. Anna, shall I jump in?
Sure. Thank you.
Thanks. So, Paul, I congratulate you on these insights. This is actually, I mean, when we talk of comprehensive, we do use the term comprehensive VPD surveillance, but this is not used in a restrictive way on the VPD. I mean, if the country or the teams therein, they decide that they would expand the comprehensiveness beyond VPDs and leverage existing systems or funding, I mean, there is nothing like it. Frankly speaking, this is a very, very welcome, and thank you for highlighting this. This is exactly the kind of leveraging, because there are commonalities between systems of surveillance, data systems, etc., and which in the local context, and each country has its unique context, can be leveraged and can be utilized, can be used. Staff time can be apportioned to different types of surveillance, and say the same staff is going to health facility, can look for AFP if well-trained, can look for polio AFP, can look for measles, can also look for suspected tuberculosis cases, depending on the context on the facility that he is visiting. So I think this is a very, very good example. Over from me.
Thank you, Annaminta. Would you like to add to that? Do you have any follow-up questions or further reflections for Paul Trini?
Yes, I just wanted to echo Dr. Bose that this is really a very good example of what we're talking about with different systems using the same support functions. So as I was saying, you don't necessarily use the same type of surveillance for tuberculosis and COVID-19 as other diseases, and that's the way it should be. But the support functions, as Paul outlined, were integrated. So one follow-up question I have for Paul that we wonder about for all of the countries all around the world is that for the support functions and the funding that are available for COVID-19, as it sort of waxes and wanes, we've all seen, but is it predicted that those sources of funding will continue and can still be used for VPDs, or as COVID-19 becomes more endemic, will then there be a pivot to maybe another way of supporting the VPD surveillance?
So is that a question for Paul specifically?
Yes.
Okay. Paul, would you like to respond to that? Oh, all right. And Paul seems to have unfortunately lost the connection. That will happen to many of you. It's normal and healthy. It's already amazing that we're able to connect in this way. It's unfortunate we won't hear Paul's answer, but I suggest we go to the next best practice and lesson learned that was shared. Yes.
We have Robert Talongwa, whose hand is raised. Maybe he could have an experience that is linked to what Paul just shared.
Okay, that would be wonderful to hear.
Roberto,
I'm asking you to unmute.
Hi, everyone, and good morning once again from Cameroon. I just want to emphasize on the fact that maybe in the context of Ghana, this integration is already formally written in official documents. Here in Cameroon, we don't yet have it. Most programs are still vertical, fragmented, but owing to discussion at the subnational level, regional program leaders have been able to integrate some of their activities. For instance, we took advantage of regional malaria data review to train GMOs on disease surveillance, because the actors, those who were coming in, were the same. We also took advantage of the COVID-19 funds when we were conducting the regional workshop to assess cholera workshop. But there was no more funding to assess the cholera campaign we carried out earlier. So we used this COVID-19 workshop to do both. But still, again, this depends on strong collaboration between the various managers at the subnational level. They need to talk to each other. They must not wait for a formal document saying that they should integrate it. They can talk together and talk each other and do something and integrate it while waiting for things to be formalized. Down.
Thank you, Roberto. I see Dauda Samuel and Hanania has their hand up. Let's hear from one other best practice or lesson learned. Let me see. Let's see. Let's go to Caroline Wanjiku Maina. Yes, and she is in the room. So Caroline, you work at the central level in Kenya, and you said in the course of establishing case-based surveillance for meningitis in Kenya, we tried as much as possible to use existing structures, including writing on the existing sample referral systems in place. This enabled the referral of samples from sites that have no lab capacity to confirm meningitis. It also enabled the proper use of limited resources. Caroline, would love to hear from you. I'm asking you to unmute. Again, everything in the course requires your active participation, so do not be surprised if you are asked to speak. Caroline, welcome. Please do introduce yourself. What do you do exactly in the national team in Kenya? And is there anything else you'd like to add to the story that you shared in your application for this course?
So good morning, good afternoon, and good evening to everyone. As you've heard, my name is Caroline Maina. I work at the national level disease surveillance and response unit, where I have worked in various capacities in VPD surveillance, including establishing environmental surveillance for polioviruses. I'm currently pursuing my MSc in epidemiology, but side by side, I'm also helping in establish, or rather strengthen, meningitis surveillance in the country. One of the, or two of the challenges that have been presented by Dr. Anna actually are troubling us in the country as far as meningitis is concerned. We have data that we cannot use to make decisions. So as part of strengthening surveillance, we also would like to remedy what is happening. People seem to be reporting a lot of meningococcal meningitis, which is not confirmed. And actually, when we called back to those sites, they do not even have lab capacity. They're not collecting CSF samples. So again, it points to data quality issues in the country. So as we strengthen meningitis surveillance, or we as much as possible try to use existing structures, use the existing sites that we've been using for PBM surveillance, use the same human resource capacity. The National Public Health Laboratory Services at national level also managed to secure some funding for sample referral. This has also been a headache for our country, not measles surveillance, not AFP surveillance. Sample referral has been an issue, mainly also because we devolved our health systems from 2013, and we've seen a lot of teething problems. So with the 47 counties, some counties have prioritized surveillance, and in other counties we see minimal support to the surveillance teams. Yes, so that would be all from me for now.
Thank you, Caroline. So now over to Anindya Sekarbose and then Anna Minta for feedback. Can you help us connect the dots between Caroline's practice and the new global strategy from WHO?
No, yeah, thanks, Caroline. I mean, this is another excellent example of sort of what the principle of efficiency in using resources. I mean, the way she's describing it, that's an excellent example. I would just like to bring up one point for everyone's attention, and this is important to understand. This is an excellent example of efficiency, but sometimes we also need to be aware of the technical issues here, particularly in this example, when you're trying to isolate a bacteriological etiology, bacteriological agent. Sometimes transporting samples, if it takes too long, may be counterproductive unless you use some other special transport materials. I don't want to go into details here. Special transport materials for transport during the time, because that may entail a delay. So I'm sure the team has looked into that. So as a principle, this is great, but when we implement these principles, we need to be cognizant of the technical issues that are involved there. I will just highlight, I'm looking at if you allow me, I'll just highlight one point here, because I look at the questions in the chat box, and there's a lot of questions of what kind of, whether it's sentinel or whether it would be population-based, what kind of surveillance system is best for the country or the context. I'll just add one sentence here, that when we design a surveillance system, at least the way one should think about is to think backwards. Think what is your end objective. If it is eradication, say polio or elimination like measles, you need to have a system where you have to get each and every case and some or other lab confirm it or AP-link those cases. That needs one type of design of surveillance. So sentinel site, of course, will not work for polio or for measles. But if your objective is to get some sense of the burden and you have a vaccine or some other interventions which will control it, and you can monitor, even if you're not getting all the cases that the burden is going up, down, or remaining the same, then maybe sentinel site is the answer. And between these, there can be a whole spectrum of different models. So try to think backwards from your objective and then fit it according to the country context and the resources available. Over from my side.
Thank you very much indeed. Anna, comments on specifically Caroline, and then indeed referring to some of the very interesting questions and comments in the chat and where the discussion is going.
Yeah, so I also thank Caroline for the example that you gave. And as you mentioned, there are some strengths to the system that you've mentioned, trying to integrate different surveillance together. But that's also raised challenges that your team, as you said, is also trying to address. And that's exactly what the process is. This is not something simple. It's not one size fits all. It varies. Like you said, some districts have support and interest in surveillance, some don't. So even within the country, there are differences that you see within different districts. So I thank you for your example, and I do think it highlights that this is not an easy thing that we're talking about. And there are lots of nuances that we all need to think about together and focus really for each of us on our specific context. What can we do to improve the surveillance? So thank you for your example.
Thank you, Anna. Now, if you'd like to share your own experience in response to either of these two examples, please raise your hand. If you have a comment, a follow-up question, an insight you would like to share, just go to the raise hand button. And yes, Dauda, Samuel, Hanania, I know you had your hand raised before, so let's go to you now.
Okay, thank you very much. Good morning,
please do introduce
everyone.
yourself.
Good morning, everyone. I'm Hanania Dauda, WHO surveillance officer working at the subnational level in Kaduna State, Nigeria. I was initially want to share the experience at the subnational level here regarding utilizing the resources and seeing how you improve integration regarding both TB and COVID. We were initially supporting the TB in terms of sustainability of funding, like Anna had earlier asked. In Nigeria, I think there is a very, very good system of funding that comes from global funds supporting TB response in Nigeria. And some of their key interventions for improving case detection include the contact tracing, like the colleague from Ghana had earlier shared. And then also community interventions like going from house to house or conducting outreaches. All these are some of the interventions in addition to screening everybody that enters all the hospitals for TB. All these were interventions that had improved TB case detection in Nigeria over the years. Now with the coming in of COVID, most of the similarities you see between TB and COVID at the subnational level, though at the national level, these are also policies that are trying to be adopted at the subnational level, especially in Kaduna State. We had to look at the similarities, and in terms of the contact tracing, we made sure that we also do that together, and that yielded a lot of results. In terms of specimen referral, there is an integrated national specimen referral network that was also used to transport TB, HIV, and other samples from the community to the testing sites. That channel was also used to transport COVID sample at the peak of the response. Also, at the community level, when they are doing the house-to-house as well as the community outreaches, that same funding was also used to make sure that persons with COVID were also tested. So that also demonstrates at the subnational level that we can integrate, especially when you have those samples and similarities. Of course, the GeneXpert that is used in testing for TB were also utilized to also test for COVID. The capacity was built, the resources were gotten, the government gave some little resources, and also the NCDC provided some. So that helped to make sure that at least wherever we are looking for TB, we are looking for COVID. Wherever we are looking for COVID, we are also looking for TB. That helped to also make sure that we use whichever funding that is available. If it is coming from the COVID, we use the COVID. If it is coming from the TB, we use the TB. At least we know that the TB is sustainable because Global Fund is always there to provide that funding. The issue is the government contribution that is the issue. Thank you, and over.
Thank you very much indeed. Let's start this time with Anna's response, comments, feedback, connecting the dots back to the global strategy, and then Anindya.
Thank you very much, Dauda, for your comments. This is another very good example of what we're talking about with comprehensive surveillance that's also integrated. So it's a good example with tuberculosis and COVID-19, using resources from one to help with the other because the basic support functions are the same. One question I have for you is, do you see a way that other diseases can be incorporated? And I'm specifically thinking of the challenge a lot of countries have with confirmation of bacterial VPD, vaccine-preventable diseases. And if there's a specimen transport in place already for tuberculosis, I'm wondering if you see a way to incorporate other bacterial VPDs in there, or if you think that would best be done in another way. Thank you.
Yeah, thank you very much, Anna, for that question. Yeah, if you look at the community-based intervention, of course, at the subnational level, we are working on doing a more integrated in terms of community intervention, where you look at other diseases that within the community where the outreaches will be taking place. The Kaduna State government were able to procure some mobile diagnostic trucks, and that the response that we intend to use with that truck is an all integrated part. So when you go to the community, you look for all diseases. It will not be restricted to just TB and COVID. Now, going to the second question in terms of the referral, I know that referral system is supported by USAID. And of course, even before we were able to bring in COVID into the referral system, we had to discuss the government. Through the government, they had to have some little discussion with the USAID coordinators to make sure that was adopted. Of course, I'm sure if we are able to look at that, that would also be available. Of course, for the other VPDs, because of the availability, the Nigerian Center for Disease Control have also a referral system wherein if you don't have a diagnostic mechanism in the state where you are to diagnose those VPDs, they have also identified a courier system that can help to transport that sample from the central collection point at the state level to the National Reference Laboratory. So the challenge here is the transport system from where the sample is collected, that is the district or the LGA level, to the center, because the courier is only engaged to transport the samples from the center to the reference lab. Now, the challenge we are having is getting the funding for transporting these samples from the district level or from where it is collected at the LGA or district level to the center. That is where the gaps is. And WHO in Kaduna State is trying its best to provide some of this funding in terms of transportation for measles. And sometimes we even use that same funding to transport other samples from where they are collected, in addition to the measles, like the yellow fever and the others. We support the transportation from where they are collected to the center. Then the NCDC takes over the transportation using the courier system that is available here in Nigeria. Thank you, and over.
All right, thank you very much indeed, and that is right on time to move into the next segment for this for today's session. So I was showing and we'll show again the course program. You can see that we're now at the 10 minutes past 10 in Geneva, Switzerland. Of course, the time is likely to be different depending on where you are. We are going to go into a new remote coffee. So you will be going into your breakout group. In principle, you should find the same people that you met in the first remote coffee during the opening ceremony. If not, no big deal. This is the group now that you will be working with throughout the rest of the day. We've just shared a lot very quickly on best practices and lessons learned on VPD surveillance. So your goal, you have in principle already introduced yourselves to each other. Your goal in the next 10 minutes of the remote coffee is to actually share your thoughts. What you listened, a few of you got to speak. Now share your thoughts, your insights. What did you make of this discussion? What did you take away from this discussion?